Now, how do we treat patients who have non-small cell lung cancer with RET rearrangements? There are multi-kinase inhibitors that had traditionally been used back in the days when we didn't have the more advanced medications that we have right now. These are called multi-kinase inhibitors because they have multiple targets, not just the RET fusion molecule. Some examples are cabozantinib, vendatinib, alectinib, lenvatinib, and sunitinib. They were approved by the FDA, and they are approved by the FDA for other indications and other subtypes of lung cancers and even other cancers such as thyroid cancers. They're significantly less potent than the newer RET inhibitors that we have. However, they did have good responses back in the days where we didn't have the more targeted and specific drugs that we have right now. I'm going to cite an example with cabozantinib. When we used to use this drug for patients who had RET rearrangements, there were studies that showed that people had responses in about 28% of the time, and about 36% of people had stabilization of their disease. The more advanced and more recently studied and approved drugs in the setting are what we call selective RET inhibitors. Some examples are selpercatinib and pralsetinib. They were studied in large trials, and when I say large trials, there are relatively large trials to other drugs, but that's because this RET rearrangement occurs in just about 1 to 2% of non-small cell lung cancer. The studies were Libretto and Arrow, respectively, and they showed that in people who have RET rearranged non-small cell lung cancer that have been exposed to prior treatments, the response rates were as high as 60 to 65%. And in patients who had no prior treatment, what we call treatment naive patients, the response rates were all the way up to 70 to 80% of patients. They also demonstrated that these drugs do penetrate to the brain, and they can even treat brain metastasis. And I'm going to show you a couple slides from the studies that were done on this. This is what we call the waterfall plot from the study that was done, from the trial that was done on pralsetinib. And just to give you an idea of what we're looking at, every bar on this graph is a patient, and the length of every bar basically illustrates the change in their disease burden. And so you will see that on the far left of this graph, there are a few people who have a slight increase in their disease burden, but the vast majority of people have decrease in their disease burden. We have a threshold where we call people that have responses to treatment, and we have to see about 30% reduction in their disease burden in order to call them responsive to treatment. And so there is a large amount of patients, about I would say 60 to 70% of patients, who had actual responses to the treatment. And then on the far right end of this graph, you do see a number of patients that had all the way up to 100% of response, which is what we call complete response. These are the waterfall plots from the selpercatinib trial, also demonstrating the same thing, where you have a few people who had progression or increase in the size of their cancer burden, but then the vast majority of patients do respond to the treatment. And you also have a few patients who have complete response of their therapy. On the right side graph, I just wanted to highlight in here that these were the patients who had intracranial metastasis, meaning spreading of the cancer to their brain. And they had, for the most part, also deep responses to these medications inside their brain lesions, which is very important and very reassuring to patients who have brain metastasis. I wanted to also highlight some treatment side effects to the older drugs and the newer drugs. The multi-kinase inhibitors that we used to do, because they had multiple targets, they also had multiple side effects, including rashes, diarrhea, hypertension, often leading to treatment interruption and dose modifications of these medications. With the newer selective RET inhibitors, they have a narrow target, and so they have less toxicities overall. The vast majority of what we see is either hypersensitivity, some hypertension, but not as common as we used to see with the older drugs. And then we also see some low counts in some cases. In the vast majority of patients, those rarely lead to interruption of their medications or the need to dose modify them. And so the take-home points here are that RET alterations are present in patients with non-small cell lung cancer. They are seen in about 1 to 2% of these patients. We do have very good targeted therapy options that are well tolerated, and they have good response rates and durable responses, and importantly, intracranial responses with effect in the brain, which sometimes cannot be affected by traditional drugs. And I would also say that checking for these alterations is the standard of care for all patients who have metastatic non-small cell lung cancer. We do hope that these drugs will be studied in the earlier setting, non-small cell lung cancer patients, and hopefully that would be the standard also to test for this in earlier stages. And finally, I'll put a plug in for connecting with other patients who have RET mutated non-small cell lung cancer. I would highlight the RET positive group, which is a patient advocacy group out there that can provide you with education on these cancers. It definitely is very helpful to provide patients and their caretakers with a sense of community. They could even tell you some patient stories that just illustrate how good the drugs that we have are and how their quality of life is on these medications. And then also importantly, at the time that people experience progression of their disease, where the cancer really outsmarts our drugs, they can also connect you with trials and other studies looking at side effects and resistance mechanisms and other parts of dealing and treating these non-small cell lung cancers that are not inherently studied on traditional trials. And the best way to connect with these groups is really social media, and that is their Twitter handle. And I will thank you for your attention, and I'm happy to answer any questions that you may have.